Thank you very much. At the very outset, I'd like to thank, Arthroscopy Society of Nagpur for being a bridge between the Indian Arthroscopy Society and Arthroscopy Society of Nepal. And then it's really an honor if you see Nepal's progress over the last 5 years in arthroscopy. And then Indian Arthroscopy Society has a major role in it by training our colleague, by providing us the opportunity to discuss in such an august forum. So today I'm going to talk about the double row cuff repair. I'm not expert of double row cuff repair, but whatever I do, I usually do a double row cuff repair. I'll talk about my opinion on double row. If you look at the incidence of a rotator cuff tear, which dramatically increases, this is a paper from 2013 by a group of Easy Toy, it dramatically increases after 50 years of age. But in Nepal, I don't know, it must be the same in India as well. These rotator cuffs are most commonly neglected injuries because this occurs mostly on the senior citizens. And the commonest presentation of rotator cuff tear is a shoulder pain. And usually they are diagnosed as a frozen shoulder and commonly treated conservatively. And very rarely this patient comes to an arthroscopic surgeon. This misconception of conservative management of rotator cuff is there not only in the patients and the physiotherapists, but it's also in the doctors. If you see this publication, which is in 2017, also says that there is no difference in outcome between surgically and the conservatively treated patient. This is a 2017 paper. This is again one of the relative newer paper, again discouraging paper, which says that there is about 20 to 50% risk of failure of rotator cuff. Probably this is the reason why the general orthopedic surgeon, they do not tend to suggest surgery. But we have to understand why this failure occurs. This failure is basically a multi-regional failure. The most important is the tissue quality. The double row is basically on the suture strength, which is very, very important. We have to provide a healing environment, and till the cuff heals into the bone, we have to provide adequate stability. So when we talk about rotator cuff tear, we are talking about a tendon to bone healing, which we know that this is very, very tedious and very weak healing process. For that, we need to have a good vascular environment. We have to have a tension-free repair. And then we have to achieve probably a wider area of healing so that healing takes place faster. And during this healing, probably we need to have a stable fixation. And for this, we all know that there are two methods. One is the single row repair and the double row repair. If you look at the anatomy, the footprint of the rotator cuff tear is not point contact. This is a wide footprint. So probably a double row more forms the anatomic reconstruction. If you see this paper, although a little older one published in 2009, but all these paper which has been quoted by this research says that double row better at footprint restoration in all the studies that has been published. Look at what happens if it is a single row repair. So when you do a single row repair, initially it may look very good, but when you start mobilizing, there is not much of stability. And if the repair is not stable, probably you have to immobilize for a longer time. So you run a risk of stiffness, and there is a chances of failure at this point. In case of double row, so when you tie with the medial row, then take the thread into the lateral side and form a lateral row reconstruction, usually with a footprint anchor. Then what happens? The flap of the rotator cuff is very much pressed to the footprint. So your footprint is wide, and fixation is stable. So you can allow an early range of motion, and then there is a possibility of the healing. There are various methods of double row repair. I'll not go into detail of that, but the one that I practice is the transosseous equivalent. I'll show you a 2 minutes video of this. This was a 54-year-old lady with this kind of presentation. Again, she was treated for about 4 or 5 months with the diagnosis of frozen shoulder, and this is how her MRI looked like. So this is for arthroscopic video. I am very aggressive to the biceps. So most of the time I reduce bicep. It will be interesting to listen how other people manage the biceps, but I am very aggressive to the biceps. So once the bicep tenotomy is done, I do a subacromial scopy. In this case, it was a U-shaped tear, but it was a laminar tear. It is important to identify the extent of the tear, which is very, very essential for the repair process, and also the reducibility. So if your tear is very much reducible, probably you don't need to do much of release. If it is irreducible, then there are so many varieties of procedure that you have to do. To improve the vascularity on the bed of the humeral head, I do little bit of debridement and decortication. It is not true decortication. I do not use a burr, but I use a shaver just to decorticate. A gentle release if it is required or if the reduction is in tension. Then I mark my entry portal for the medial row. Usually I use a doubly loaded 2 suture. Then I make a crimson duvet with the same tab and then pass 2 screw to infix and then take out all these sutures one by one above the rotator cuff into the subacromial space. So these are the process. All the 8 limbs of doubly loaded 2 suture anchors has to come out, and probably it has to be spaced adequately in equal distance, not less than 5 millimeter. So once you get it, all the sutures above the rotator cuff, then I tie. There are controversy either to make a knot here or not, but I make a very loose knot over the rotator cuff and then take one limb from each of these knots as a lateral row. So here I'm releasing the greater trochanter, the lateral aspect of the humeral head. Take each limb from all the knots and I use 2 lateral row anchors. So this is one lateral row anchor and then you put another lateral row anchor. If you see this reconstruction at the end, this looks beautiful and very good footprint contract and a very good compression at the footprint of the rotator cuff. However, if you see literature, what they have to say when they compare double row with a single row, there is basically no difference in the functional outcome, whatever you do, either you do a double row or you do a single row. But it is important to know that the failure rate, although some papers say that the failure rate is not different, but majority of the paper, they say that the failure rate of the double row is significantly lower compared to a single row. However, if you see this animation, the single row fails with a type 1 failure. That means it fails from the bone to the tendon attachment at the repair site. So this is type 1 failure. If you see the double row, that fails from the tendon. So the repair site is intact, but it fails from the tendon. Probably revision of a type 2 repair is more challenging and difficult compared to a repair of a type 1 failure. This is the only thing that hinders my approach to the double row, and I make sure that the tendon quality is good before I do a double row repair. So to conclude, whenever possible, I always do a double row repair for the rotator cuff. Thank you very much.